All right, if you have joined us already, welcome. We'll get started soon and you'll see a poll pop up here. If you could complete that for us, helps us improve. And we'll get started shortly. Okay, good afternoon or good morning, depending on where you are joining us from. We are delighted to have you on our substance use disorder webinar series, the final of our series. Today, we're going to focus on Q&A session to respond to your questions that you've submitted throughout the last several sessions, and then in anticipation of this session. My name is Ellen Eaton. I am an associate professor of medicine at UAB in the Division of Infectious Diseases, and I'm joined by my colleague, Dr. Sandra Springer, who is a professor at Yale School of Medicine. As a reminder, there is a new DEA training requirement, which we've developed this session to respond to. Please note that this is a Q&A session. It is not eligible for CME credit. However, we do have many CME eligible courses on the website. As a reminder, our full resource center includes many talks from Dr. Springer and myself, several other experts. We encourage you to look for a total of 8 hours of CME credit available. As a reminder, there is a national substance use warm line that we encourage you to write down for patient care issues. It is cost-free and confidential. A reminder of our financial relationship with ineligible companies and our content on the web board. And then for myself and Dr. Springer's relationships as well. This activity is sponsored by and funded by the IAS-USA. And just for a few housekeeping issues, you do see a poll and hopefully have completed that. There will also be an option for you to submit questions using the Q&A button. The chat is open, but we encourage you to submit your questions to the Q&A session specifically and not the chat so that we can answer those. All right, without further ado, we can see here the poll responses. Very interesting to see your participation. It looks like about 56% of you have completed or participated in all of the courses, so thank you. And some of you are new to us. It looks like about 28% have not participated in the session, but we hope this session will still be helpful. Feel free to put your questions in the Q&A bar, and then we'll also address questions that came in ahead of time. So let me go ahead and get started. Great. So Sandy, good afternoon to you, right? In your time.
Yeah. Yes. This is
really,
awesome.
Yeah, really excited. I know I have questions for you myself, but also questions that have come in. I thought I could just get started with the first question that we had come in around contingency management. And this came in specifically for today's session. So I did want to just start by pointing our audience, especially those who didn't participate in the series, to Dr. Shoptaw's lesson. I know we both really enjoyed it. This is specifically on stimulant use and contingency management. Some great resources there available online. But also, if you could just, Sandy, I think you use contingency management in your practice. Do you mind giving us an overview of what you've used or recommend for our colleagues on the call?
Yeah, no, thank you. And again, echoing what Alan just said, that it was an amazing talk that Dr. Steve Shoptaw gave on stimulant use disorders and really reviewed all of, I'd say, a complete history of treatment modalities, including medications, that have been evaluated, although not currently any FDA-approved medication treatments for stimulant use disorder. There is some compelling data And then contingency management, as was identified in Dr. Shoptaw's talk that you can watch, is the most effective evidence-based intervention to treat both cocaine and methamphetamine use disorders. And I won't go into detail, but again, in that talk, he describes how you would actually utilize an incentivized based mechanism, which is what contingency management is based upon. In terms of our experience, so there are monetary incentives and then there are non-monetary incentives. And the typical one, as Dr. Shoptaw describes, and what many have heard, is the fishbowl kind of one where you might have inside the like a pretend fishbowl little incentives that could include anything from a free bus pass to, a gift card, or maybe even smaller tokens that can mean a lot, like, doing a superb job of completing this many visits. But the goal is to provide some incentive that might help somebody reduce their amount of use. So it's knowing what one is doing currently, how many days or how many times a day that someone is using a substance, and seeing and finding a goal of what to reduce that to. And for some, it's complete abstinence. And most of our research studies show that. And others, it could be reducing to a certain amount that reduces potential harms to them. And so the types of things that we've used include gift cards, like we said, bus passes, minutes on cell phones, things like that. And then some have been actually certificates of achievement that can be framed of completing so many visits or coming back, which has a lot, coming back and helping with your sobriety, which has a lot of motivation for many people of this success. Even notepads after each visit that, might have an A+ or some type of, positive feedback. So those are kind of some of the incentives. And again, the goal might be linked with our HIV treatment. It could be, so it doesn't have to be just incentivized just for the substance use. It could be through also linking that to coming back for your HIV care appointment, or taking antiretroviral therapy if they were having difficulty with that. So, and you can also link those incentives in that particular aspect. But that's the goal of contingency management, is trying to assist in some form or way through an incentive, and determining what that incentive is, and to reducing harmful substance use, and can be linked, of course, with HIV care too.
Yeah, love that. I will say I'm in a Ryan White clinic, and as you know, we have limited resources, but one of the things we do that is contingency management in a way is spacing out visits. Once people reach a stable dose and they are not having cravings and they're adherent, we start spacing out their visits, and in a way we're giving back their time. So I do view that as a little bit of a contingency management. I know I have a colleague who has a fishbowl with growth mindset, cards, and has said that that's been really inspiring for her friends, or sorry, for her patients. Thinking about non-traditional things for clinics who may not have a lot of resources. I know that our peer gives small little journals, and this gets to one of the next questions around mindfulness meditation. Not the exact same thing, but our peer gives out little journals for patients as kind of a keep up the good work, and encourages them to journal. And getting at this second question, do you do anything formally around meditation or mindfulness, or have you had experience with those programs in your practice?
Yeah, I think it's a really great suggestion. I personally have not, but my peers or community health workers that we have that work do provide that, or ask that as a need, if somebody might have a need for that, or recommendation. But I have not implemented that, and my clinic settings, but there's definitely good evidence to support that it can assist in someone's road to recovery or sobriety, however you want to frame it.
Great.
Yeah.
The last question that I got from the Q&A for today that hasn't been addressed is around syphilis. And I know you and I have talked about this informally. I'm in Alabama, and we are one of the syphilis hotspots. We've seen an unprecedented number of congenital syphilis cases, which is obviously an event that we should not see in 2024. And the question just asked us to discuss the role of substance use. I can speak to my community. We don't have an integrated women's health, reproductive health, substance use care model. And similarly, our public health infrastructure is not evaluating these two things in an integrated fashion. So we know our syphilis epidemic, we know our substance use epidemic, but I think we have a lot of room to improve in terms of measuring and managing syphilis in women who use substances and these really devastating outcomes in women, which the question was specifically around women. Do you have a integrated clinic there? Do you have recommendations for our colleagues who may be seeing a rise in this population and want to address that nexus?
Yeah, no, it's really sad, and it's really sobering in itself to see the latest numbers from the CDC. And in fact, I was even asked by people who are not medically trained, why are we seeing syphilis numbers increase? And definitely this, in many areas, unfortunately, we're seeing in the areas that people really need the most, dismantling of public health services that included free STI testing and other important services. And so it is really shocking. And then to see the congenital syphilis rates that are rising. I don't, I was in a Ryan White Care HIV program, and now I'm in, I do most of my work in the VA, so I integrate kind of STI testing with everything. And then in my clinical research and other hat with those who are involved in the criminal justice system or criminal legal system in carceral settings, is knowing that those numbers are much higher and potential risk behaviors and substance use. And yes, substance use does cause, as we know, potentially through condomless sexual intercourse, through disinhibition properties, or sharing, exchanging sex for drugs, or sex for money, which unfortunately hurts many of our a population that identify as female, is this increased risk of STIs like syphilis. And so we need to be always cognizant of being able to reduce barriers to offer free testing if you can, or in a linkage immediately to treatment if the test is positive. So we're doing a lot of that and integrating care, including on mobile health units, and really just kind of reducing stigma and reducing the barriers that people have, because you have to think about it. Where do you go? You might go to a substance use treatment program, and not all substance use treatment programs are offering integrated, obviously, STI testing or HIV testing. So knowing where to go, and then go to another another clinic or another testing center, or if you have Planned Parenthood, that's great if you're a woman, but Planned Parenthood may not be available for you. And it is really, really difficult. But we're seeing all infections in persons who use drugs rising: STIs, HIV, hepatitis C, infectious endocarditis, as you know. And so these are all opportunities wherever individuals are interfacing with people who might be using drugs, to offer these testing and screening and integrated care models that really, even if it's not your level of expertise, knowing and having somebody that could be available who could offer treatment and prevention recommendations.
Yeah, and I think that's really the spirit of this series of talks. As you're talking, I think it's the second session where we talk about screening. And you could imagine if the people on this call who treat women and women's health did more substance use screening and treatment, and the people on this call who do more substance use screening and treatment started thinking about syphilis and other STIs
Yeah.
and infectious complications, I think, the problem does seem overwhelming, frankly, when I look around and see the need in my state. But if we could get this material and this training to more people who don't identify as addiction medicine providers, but are routine primary care doctors, I think that is chipping away at this issue.
Yeah.
And that kind of is a segue to one of the questions or requests that came up for today. And Sandy, I know we've emailed about this and we need to think about a way to put together some resources, because one person did specifically say a packet, a guidelines, some sort of material for busy practices, busy clinicians. And I think that does get at one of the challenges with increasing the number of prescribers is that we are primary, in HIV, we are primary care providers. Many of us work at FQHCs, we're doing Hep C, we're doing contraceptives, we're doing all the things. So that's something that maybe we can put our heads together and think of a way to put some information and materials for our colleagues on the call who want to start treating substance use disorder. So we'll work on that.
I think that's a great idea. It's the how-to. And so the implementation, how would you build this in? What is it that you do? And, what's the next step? Like, can you provide the treatment? So I hear maybe from addiction psychiatrists, maybe not feeling comfortable in doing the STI testing. But if you did the STI testing, knowing who it was that if you didn't feel comfortable with treating that STI, what would be what should you do? Should you have a nurse available who can provide treatment, or is there a provider that is in your near that you could refer them to, or local clinic? So I think it's knowing what to test for, what to assess, and then like you said, for substance use, really feeling comfortable on either providing, if you don't feel comfortable, I guess, providing the treatment, knowing who could provide the treatment and in a timely way. So not like a couple of weeks later, like really giving somebody that information. So I agree with you. Giving some of those tools that we've developed, would be happy to share.
Yeah, absolutely. And Sandy, if you have questions that you're interested, I'm just going to pull from our list, and feel free to volleyball back and forth to me. There was a question that came in early around addiction and HIV, and does substance use increase the viral load, accelerate disease progression, worsen AIDS-related mortality? And the question was, how about people who are on ART and taking ART? Does substance use have a relationship or an impact on those? And what are your thoughts on that?
Yeah, and I think, I can't remember if it was in the first session, maybe in the second session too, we tried to kind of overview that. And that, that's the heart of probably what I do the most in my research. But yeah, so all forms of substance use in a nutshell, just and it goes not just opioids and stimulants, but also alcohol, and there's data for nicotine as well, to that increase not only the ability potentially for risk of developing HIV if one does not have HIV, but if you do have HIV, can interfere with the whole HIV care cascade, including inability to adhere to potentially antiretroviral therapy, which then leads to viral elevations in the viral load. And then, of course, from a prevention standpoint, if someone's partaking in a condom sexual intercourse or sharing, say, injection drug use equipment, that can then lead to transmission to somebody who doesn't have HIV. Interestingly, there's some data to support when we treat substance use disorders in individuals with HIV, you can improve the likelihood of improving, obviously, adherence to antiretroviral therapy through potentially, decreasing the need, or improving, the ability to stay in care, because you're not accessing drugs, and it's not interfering with your ability to get to appointments. But the other part is that there is some data possibly looking at that medication treatments can potentially affect HIV latency, inflammation, And so maybe more from a basic science aspect too. And so there's data looking at buprenorphine, methadone, and some data about naltrexone for opioid use disorders and alcohol use disorders. So the method could be obviously improving adherence to improve viral suppression, but also there might be some basic science data to support improved a direct effect on HIV. So it's kind of compelling and interesting, and there's lots of researchers looking at that right now. But
Yeah.
again, it brings to the point that we need to integrate care, right? And so we can't assume like that. That's why it's so important for our patients who do have HIV to assess substance use and try to help them the best way we possibly can in treating their substance use, so we can help improve that HIV care cascade and reduce their likelihood of having higher morbidity or mortality from HIV or non-HIV related consequences, but also from a prevention public health standpoint, reducing HIV transmission. Yeah.
All great points. One question that came up a couple of times, and I know you and I talked about this kind of myth of disinterest in substance use treatment. And I think it does depend on where you're seeing patients. For example, when I see patients in the hospital, I have had some that are disinterested in treatment, such as Suboxone, because they're in acute pain, because they, want to focus on pain control and maybe they have a surgery coming up. But as a general rule, in my outpatient clinic, and really many in the hospital, when offered treatment for substance use, have been very interested in wanting to start. And I know that a lot of the research you and I have done is that patients aren't offered addiction treatment, and that's really the barrier. I know we've showed in some of the slides that I think like only 1 in 5 patients who have an opioid use disorder have been given a prescription for a medication for opioid use disorder, and that's barriers on our side, the provider side, health insurance access to care, which is really what I see in my clinic. And another example from real world is that we've had patients come back to HIV care since we've opened our opioid treatment clinic. So,
Right.
we've been a Ryan White low barrier clinic for patients that have been diagnosed with HIV, but they haven't been in care until they heard that they could get Suboxone, and they're coming back to clinic, they're getting buprenorphine, they're getting HIV treatment, and their overall health has dramatically improved. And
Yeah.
I'm curious your thoughts on this kind of misconception that patients don't want treatment, and maybe other barriers that you're seeing on your end.
Yeah, no, and I'm glad you brought up your clinic, because I do want to ask you more questions about it. And for those who don't know, who are listening, Dr. Eaton has developed with her colleagues one of these most wonderful integrated care clinics that provide low barrier access to substance use disorder treatment, as well as HIV prevention and treatment, and really putting together a group of individuals that can also not just take care of the biomedical aspects, but also the other needs that are so essential. So, kudos to you. And, I think you'll have a lot of really important information to share with everyone on how you do that, because it is very rare. And I just want to point out, not all Ryan White care programs, as we know, are created equal. I think it was Asher Stranz's group and others that, evaluated that sadly and found out not all programs provide opioid use disorder medication treatments for opioid use disorder. And you'd think they would, but they don't. But the point being, what you said is, if people feel comfortable and feel like they can trust you, and you're not going to punish them, you're not going to stigmatize them, they're more likely to ask for help. And absolutely, what you just stated and what you're showing in your clinic, as well as what's been shown in other, clinical research trials, is that if you do offer people assessments and treatment in a non-punitive way, they're more likely to disclose. And importantly, if you can offer them the actual intervention, the actual treatment, and reduce the barriers of maybe going to another clinic or telling their story to another person, they're more likely to accept treatment. And one can lead to the other, right? One, like you said, if you offer buprenorphine, they might be more accepting of HIV testing and PrEP, or, other things like that. So I think that's absolutely critical. And that I did see that question, that it said, I've heard that 95% of people who use drugs are not interested in treatment. That was one of the questions I think you're identifying. And, I think what there's a national household survey data that might have stated that. But again, you have to think about what is treatment and what were they offered and were they offered treatment. So many, it's punitive, mandatory counseling, mandatory behavioral treatments, and so I think that number is not really representative actually of what we see. And remember, it also excluded individuals who might be unhoused, the survey data, and those who are involved in carceral settings, so which have higher numbers. And so just being cognizant of that. And I think if the one point that we should, with all the series that we've put together, is you should ask. And when you ask, make sure you have a plan. So if you're going to ask about substance use and substance use disorders, have a plan for that, where you would refer or offer treatment. And if you're going to do HIV testing and STI testing, which I think highly recommend you do, you probably know your local provider or someone who can help provide that treatment. Unfortunately, all the people who seem to be on these calls are ID or HIV kind of related. So I don't think that's really the issue. But I was going to ask you, some of these questions are also, we've touched upon in all of our lectures, but I'd like to get your feedback. Two is, like, for instance, one of the questions, what's the if somebody continues to use drugs while you're providing treatment, what do you do? What do you recommend? And one of the questions, I think, was related to, do you keep providing them, say it's buprenorphine for opioid use disorder, they're continuing to use, what are your recommendations for that population?
Yes. So this is very much a case-by-case discussion with the patient, and it's a substance by substance. So my clinic, we really focus on opioid use disorder. And I will just go ahead and say, I had clinic yesterday. I have a lot of patients who are in recovery for opioid use disorder and still struggle with stimulant use disorder. And we have to talk about that, just like diabetes and hypertension. They're two different disease states. And I have heard of outside providers stopping buprenorphine, which is a treatment for opioid use disorder, because a patient is using marijuana or they are using cocaine. And that makes just as little sense as stopping someone's antihypertensive because they are not compliant with their diabetes regimen. So I would encourage you to think of these as two different disease states. It's more challenging when the patient continues to take non-medical opioids and they're receiving buprenorphine or methadone, or, those would be the two that you would see them continuing to receive non-medical opioids while receiving a prescription for a medication for opioid use disorder. I counsel my patients. I remind them that meds for opioid use disorder are harm reduction. So if my patient either intentionally or inadvertently is exposed to fentanyl while they're in care and receiving buprenorphine, that buprenorphine is going to be somewhat protective against overdose and adverse event. It is not 100% safe. So I would never encourage people to continue using fentanyl while they're on buprenorphine or methadone. However, I do remind them that this is harm reduction. Where it gets, and I continue to treat them and counsel them and encourage inpatient treatment and have my peer check in with them, I will bring them in more frequently. We will have the social worker and the counselor all get together in the doctor's lounge afterwards to discuss how we can treat the underlying trauma that's never been managed, the anxiety, all the things, housing. We really try to have a multidisciplinary approach to those patients. But the reality is, this is a very vulnerable group by virtue of already living with HIV and opioid use disorder. Some of them will continue to use while in my clinic, while in my care. I will say, as a general rule, and you have data on this, Sandy, that even reducing their opioid use has been shown to be associated with improved HIV and other health outcomes. So abstinence is not feasible for some patients, but they still, by reducing their use, by being in care, by seeing you, by being on medications, can improve HIV outcomes, which reduces HIV transmission, which also increases the likelihood that they're going to get Hep C therapy and cure their Hep C and reduce transmission in the community. So there are a whole host of positive outcomes that we see, even for our patients who are on medications for opioid use disorder but continue to use opioids. I will say one area that's challenging, I've had a patient recently who continued to dabble with methadone and other opioids. And at a certain point, we had to have a discussion that this is a medical clinic. We do have a treatment agreement that they will not get medications from other providers. We do have a PDMP where I'm reviewing that. So there are cases where we've had to have really hard discussions and give patients options. I'd say that is a great time to discuss if they need to be in a methadone program where they can be seen daily for more accountability, if they need to convert to a long-acting injectable buprenorphine, so because you don't feel comfortable giving them a prescription, for example, that maybe they are not using in a safe manner. So there are other options for them. I like to give them options. I will say there are very, very few patients that I've stopped providing medications for opioid use disorder. Again, because our clinic operates in a harm reduction lens, we know that some care is better than no care, and we've just seen a whole host of benefits to patients' HIV and substance use behaviors when we keep them in care and keep them on medications for opioid use disorder. So that's a really long answer, Sandy.
Yeah, no, but it's awesome. And I think it really shows you got to ask, you got to talk to people, you got to support them. And sometimes it's not just a quick, easy answer. There's other things going on. And you and I had written about this, and now happy to say, and then IAS-USA antiretroviral treatment guidelines that were published in JAMA of December of 2022. It seems like it was just last year, but there's a new section on in ensuring that you integrate substance use disorder assessments and treatment in your HIV plan. And importantly, there's a couple of reminders on how to ensure access to care, low barrier access, and providing those other needs that are so important. And it is important in terms of the question that you had about long-acting injectables. There was a lovely lecture that we also had in this series by Michelle Lothwell that you were moderating, that really goes over those long-acting forms of buprenorphine and who to consider them in. And definitely you can integrate them in your HIV care, just like long-acting injectable antiretroviral therapy and PrEP. I think hopefully we'll start seeing more. But again, the problem with that, of course, is they are expensive and you need insurance. And so that's also provides limitations. But some of the questions that I think we addressed is, one question was, what are opioid? I don't use the term opioid substitution treatment. I use opioid medication or medication treatments for opioid use disorder, but that was the term they used in adherence failure. So what are some of the reasons why? And you just addressed that someone might not be able to take their treatment. It could be that the daily sublingual film or tablet of the buprenorphine, Suboxone preparation. It could even be missing methadone, which unfortunately has to go to a licensed OTP. And some of those reasons are, you have to ask them, like, is it because you can have transportation? Ask them what their reasons are. Could it be that they had a sick child or a job they had to go to and they were unable to come back to get their refills? Or there's other reasons for why. And we all know through HIV care, there's a very rich literature on reasons for poor adherence or difficulty adhering to regimens. And so we really need to think about that from a substance use disorder treatment. And it's not a failing. It's just like you were saying, it's a medical, it's a medical condition, and anyone can have difficulty adhering to any medication. So so just assessing that and helping them is really important.
Sandy, hearing you talk, I was just thinking of a case I saw yesterday, and I'm curious if you are seeing this population. It is not one that I see often. It is a 60-year-old woman, so older, and she has cognitive impairment. She's had a stroke and has taken methadone, but due to her cognitive issues, she thinks she takes it every other day. And, she's new to my clinic. We did get a urine drug screen, and lo and behold, she's got methadone, oxycodone, hydrocodone, so I think as we as HIV providers care for this population and as they age, we're going to see more of this cognitive impairment overlay. My interpretation is that she has had chronic pain and she's just taking from friends and family and not keeping up with it. I think there's a role for the long acting injectables in someone like her. She'd need a lot of counseling and reminders about taking pills. But I'm curious, this is not specifically a question that's come up, but I know a lot of us are dealing with an aging population with HIV and opioid dependency. And I'm curious if you see that in your VA population.
Yeah, no, it's a great question. And I think we've somewhere I've talked about this, but this not in this session, but hey, it's another one we could talk about. We're coming up with special populations, those with comorbid pain, those with, those who are pregnant as you're aging. And I think, that's something like through my training and your training, we don't just say, oh, are you taking your medications right? We like get into, oh, do let's talk about your medications. So they were last filled here, and how many have you missed, or whatever, and you go into it all. But I think I definitely see that. Like I've been shocked at patients I've been following for a while, and then suddenly it's not sudden, but you've noticed that there were some differences, and I think we have to be. I've become more, I guess, diligent in really trying to assess if there might be any neurocognitive challenges, memory, and assisting the best I can in how to help them, which may not be just a medication box, and it may not be an alarm system. There might be other things that we have to think about to help someone remember. But yeah, I bring up long acting injectables all the time in my population who doesn't have memory problems, just offering like, these are current treatments. But I want them to be aware. But that would be somebody that I might think about. Now, this person you were saying might have a comorbid pain disorder. And so one thing to note is that buprenorphine, it's not a super great pain treatment. It's a partial opioid agonist, partial opioid antagonist, but it does have pain. It can treat pain. And so the long acting forms, there is evidence that it can reduce pain in terms of how much, what type of pain, all of that, there are variations, but it may not be the only thing, but that might be a good option if the person's not able to remember. There's some concerns about those adherence issues, and then whether you need supplemental pain treatment on top of that. But it's certainly not a contraindication to somebody who's on opioid agonist treatments, and it might be more helpful. Yeah.
That's a good point. That actually is one of the questions that came up in one of the earlier sessions that I was looking at, is care of the patient who is on medications for opioid use disorder and needs surgery, and how you manage those short acting opioid agonists. This has come up for me a couple of times, mostly with dental surgeries. We know our patients with HIV often have poor dentition. We see abscesses, we see people that need extractions. And we know this is also a way that many of our patients end up with opioid use disorder, is indiscriminate prescribing practices. They get one dental surgery and they get 2 months worth of opioids, right? So I think a lot of our patients with opioid use disorder, whether on treatment or not, are going to have an indication for more opioids. And I'm curious how you do you see many of those patients? Do they get seen by a specialist for pain management? How does that work for you?
So in the VA system, there's a pain management program, but there's now more interaction. It depends on what system, where you are, of active primary care and other specialists in providing care. But I could say from our hospital study, that our NCAT study, where we were at, it varies, right? And sometimes you're limited because there's certain surgeons or certain other providers who are absolutely adamant that you can't provide, say, buprenorphine treatment prior to their surgery, but there's lots of evidence to support that even in cardiothoracic surgery with valvular replacements, that buprenorphine does not harm an individual and that you can do that. But you could do, one things we're doing are like low dose or 2-3 times a day, 2 to 3 times a day buprenorphine products. We have had people who've been on longer acting buprenorphine, but typically we try to not do that in the setting of somebody who's going to have a major surgery. But it doesn't prohibit one from having surgery. It's just that the anesthesiologist and the providers need to be aware of it. And I think, just being pretty open to patients. And I think there's a lot of myths out there too that people might hear. And just being aware that you can kind of provide some education or resources for them to turn to if the family member or significant other is might be questioning the use of it. I think the go-to right now is typically thought of as, oh, if someone has an acute pain need, then they need to be on methadone if they have an opioid use disorder. And it's just not true. And there's a lot of good evidence that it says that you could still co-treat their pain with a buprenorphine product that can co-treat their opioid use disorder. And even those who don't have an opioid use disorder, buprenorphine is also a potential pain agent that someone could use. So, yeah.
And I do, just in the general outpatient setting, I do have a fair number with chronic pain who choose to split their dose, their buprenorphine dose, so that it is TID. And I know that we have heard from one of our, I think Dr. Lafwell, about for some patients, taking their medication multiple times a day can reinforce their old substance use patterns. So as a goal, to use buprenorphine as a once daily long acting, but acknowledging what you said before, which is that the analgesia of buprenorphine will wear off quickly. So I do, for that reason, for my patients with chronic pain, many of them it's HIV related neuropathy, and they take their buprenorphine twice a day or 3 times a day. Many of them know when their pain is going to be worse. They're working in physical jobs, and we'll try to exploit that analgesic component of the buprenorphine for pain control, and also getting that long lasting treatment of withdrawals, cravings. Do you see, I'm guessing in the VA, there's a fair amount of that chronic pain overlay and need
Yeah.
for.
Oh yeah. There's lots of chronic pain and there's different specialty providers, and not everybody does the exact same thing, but it's nice that there is support for that. But that is typically what you see in pain, those with underlying pain disorders, is that 3 times a day dosing seems to be more helpful. And for patients, the one thing I have noticed, I just want to point out, is when I start seeing that patients are, I always ask about craving every day, just like we used to ask about the pain scale 1 to 10. I always ask a craving question, and I always have them keep that in mind, like whatever it was where your craving was the lowest and you're doing fine without using, that's where we want to be at. And if they start noticing that number is ticking up and they could be craving, and then if they have used, I do ask about how if it is a sublingual buprenorphine film or it's a tablet, is sublingual tablet or film, are they split? Did something change? Because that we know that is there something else that's interfering, and it could be how they're taking the medication, which Dr. Leish, I think, on one of our lecture series also went through how to take the medication, or could they be splitting the dose? And then, as you just described, for opioid use disorder craving, we really want, at least 16 milligrams daily. And now with fentanyl, it may be upwards of 32 milligrams, or a dose of a long-acting buprenorphine injectable with additional sublingual buprenorphine. They may need that. And so really identifying, are they craving and are they using, and how are they taking the medication? Are they waiting for it to dissolve if it's a tablet? If they're not and swallowing it, they're not getting the right amount. If they're splitting the dose, taking 8 milligrams in the morning and 8 milligrams at night, that might also be affecting it. So really diving into that. But that also means you got to ask all the time too, because it may
Yes.
feel comfortable. They might, and especially if they're a new patient to you or have been involved with the carceral system or any punitive substance use treatment program, they may not disclose that to you, that they started craving more using, because it might have been that they were accused of selling their buprenorphine, and maybe they did, I don't know, but they're less likely to disclose. So it's really asking every time and trying to dive into that.
I think that's a great reminder, asking how patients are taking their prescribed medications and their non-medical.
Yes.
Every now and then I'll have a patient who's like, I just don't feel like it's worth working, and we have to go through. You can't just swallow it. It is a
Right.
sublingual medication. It's something I'm working with my trainees to always ask. And then similarly, I think there's some patients that we know they use meth. They tell us they use meth. It's always in their system. But it matters. I have patients who swallow it. I have patients parachuting, I think is what they call it. I have patients who inject it, and it matters, right? Because all these risk behaviors, are they injecting? If so, where do they get their needles? How do they inject? Where do they inject? What does their skin look like where they inject? So I think just a good reminder for all of us that we should be asking more questions about how they're taking medications, you
Yep.
know, and non-medical substances. And a reminder for myself as well.
No, I
Okay.
know. I always ask that too.
Yes, yes,
Of myself, make sure I'm asking. Yeah.
yes. It looks like we have about 13 minutes left. I'm just going to pick through some of these remaining questions that have
Yep.
come up over. And Sandy, if you see any that you think
Yep.
we need to emphasize, please speak up.
Okay.
A question about drug interactions. And I think this is one of the big concerns that people have in treating opioid use disorder. Buprenorphine seems scary. You hear about precipitated withdrawal. You worry about drug interactions, long QT. What do I need to worry about? And I think it's in our second talk that we go through drug interactions as part of this series. But I think the general takeaway is there are very few, right? Thinking about first line HIV meds, Hep C meds, a question around alcohol and buprenorphine. And I think the general takeaway is that treating, first of all, opioid use disorder is such a highly morbid and high mortality state that we all need to be thinking about treating it. There are very few contraindications between HIV treatment, Hep C treatment, other medications. I know we used to say no benzos with buprenorphine, that it was, thought to be a very serious contraindication, but now we actually screen for sedation in people who are on benzos already. I'm just going to avoid the whole discussion of when and how benzos should be used, because that's out of scope. But I think if your patient does have an indication for benzos and you're concerned about starting buprenorphine, counseling for sedation, checking in. I have quite a few patients who have benzos prescribed for a psychiatric or other condition that have done just fine with buprenorphine. Alcohol, I think the main takeaway there is that there is naltrexone that we've talked about in at least, I think Dr. Chandler talked about it the most, can treat both the opioid use disorder and alcohol use disorder. So you may want to consider that medication instead of buprenorphine for your patients with opioid use disorder and alcohol use disorder, because that medication can treat both. Have you in your practice seen any drug interactions, even side effects? I very rarely see.
Yeah, so the good news about HIV, and we just wrote one article is forthcoming just on it's on opioid agonist treatments and HIV, and another one is others. But there's as we know, the first line treatment for HIV integrase inhibitors, there's no interactions with buprenorphine. And the other medications that we currently use are really not interacting. And then with hepatitis C treatment as well, the current hepatitis C treatment. And then with alcohol, a lot of concerns I hear are people worried about liver toxicity or, other treatments. But the worst thing you could do is not treat their alcohol use disorder or their opioid use disorder. And one, alcohol obviously can lead to cirrhosis and death. But two, any use of opioids now could increase risk of overdose. So the other bottom line is there's no contraindications for co-occurring hepatitis C or hepatitis C alone, to start, or don't need to do LFTs to start buprenorphine treatment. And then the QTC prolongation, there's no evidence to support even the long-acting form of buprenorphine, especially have not shown to prolong QTC. So you don't need that EKG before you start. And then for benzodiazepines, the only data that ever was associated with buprenorphine and increased risk of death was in when people were injecting benzodiazepines in France with and there was of course increased risk of sedation. So if somebody's on benzodiazepines, there's no reason why you can't start the when you want to start buprenorphine. There is, of course, if someone has a benzodiazepine use disorder or sedative hypnotic use disorder and severe, you still would treat their underlying opioid or alcohol use disorder, but you just have to be aware and counsel them that increased sedation is possible when you use benzodiazepines or drink alcohol when you have another co-occurring substance use disorder. But yeah.
Yeah. It's all good news for those of us who are new to the field and may have some concerns. Sandy, one question about a substance use we haven't addressed during the session, tobacco cessation screening and how to incorporate screening for tobacco cessation. I know that my clinic incorporates this with routine screening, but I'll tell you one thing we don't ask about that I would like to is vaping. And so often I'll get a patient who has said 0 cigarettes. And then when I ask them, yeah, I don't smoke cigarettes, I vape. And, I think there's this whole field that we're, just an has emerged. But the literature I think is lagging. And I don't think we really know how many of our patients are vaping because I don't know that we ask. Do you
Good question.
routinely screen for tobacco or vaping or both? And how do you do that?
Yeah, so we did in Dr. Gitanjali's Chander's lecture on alcohol and nicotine and tobacco use disorder. I think she just drives all the screening methods. But I agree with you. It's similar to how we ask alcohol, right? For some patients, if you say, do you drink alcohol? They'll say no. And then they're like, I only drink beer. And that, this idea that beer is different. So you have to give them some ideas. But I think now with vaping, if you ask, do you smoke cigarettes, which is typically our screening question that we were, trained to ask in medical school or however whatever your training background is, you have to open that up now and many are vaping. But I do agree with you that those assessment and screening tools are not necessarily all incorporating the vaping. And then what do you do about it? So everyone describes, if you look at the literature, says, oh, vaping's more healthy because it has less of the carcinogens than smoking. But we don't really know. And there's a lot of support, especially in younger populations, teenagers, that there might be some neurocognitive deficits and obviously pulmonary. So there's a lot of things that we don't know. And I'm not sure, for me, I have not incorporated, sadly, a general question about vaping. And I'm thinking about, what would I do? What is considered too much vaping? Like how we could get to tobacco or alcohol or, that I think that's really important information to give back to the clinicians. And then what are you going to do about it? So what are you going to offer? So once we do know whatever that is, that threshold, what can we offer to somebody? And there is research going on about now vaping and cessation, but I'm not an expert in that area, but that might be another topic we could add to this one.
We could all learn together. One final question I'm going to ask, and then if you have any finals, I think we can wrap up. This just is a question that came up in the second to last section, and they ask about substance use screening for patient care. And I think it's stigma screening,
Oh,
stigma around substance use at the patient level. So I know you and I have screened for stigma when we're thinking about clinical research.
sure.
And it is
Yeah.
an interesting question to understand how accurate maybe our reporting is when we screen for these substances. We know there's a lot of stigma. This question specifically was around meth use, but I think there's even stigma around tobacco use, and our patients may not want to disclose because they know we counsel them every visit and that we are hoping they'll quit. I am not aware of anybody using any substance use stigma screening for patient care. Are you?
Yeah, no, it's a really good question. And I saw that one as well. And I'm glad you brought it up. And that's the exact same response. I was going to say I use it in research, but I'm sure there is, and I don't know what it would be, but it's a really good idea. And then how it would inform your treatment recommendations. I think that's like at first it comes down to how are we asking? And I know for a fact, all our colleagues and others don't ask. And so I don't know what a screening tool for stigma if anybody who's listening and knows for clinical care, please share. But that's a really good question. I don't know. And then I think there was one question about evidence-based interventions for sexual and gender minorities using crystal meth that address both substance use, HIV prevention, and HIV treatment engagement, wondering what are the evidence-based interventions for those populations. And I think there's a lot of research that's going into, there's many, that are kind of working on this, but really honing in on, not all populations are created equal, and what is it that we need to do to help kind of guide these interventions for different populations. Yeah.
Yeah. Integration, right? We know that integration works, integrating
Asking
treatment.
everybody. Yep.
Yeah. Yeah. Well, great. Well, I think that is all our time today. We didn't get many questions in the Q&A, although I see that our team answered one regarding the certification and for this course. Thank you all for joining us. We do have a few housekeeping slides to close. Just a reminder for several sessions. We've got a podcast coming up with Dr. Mike Sag going antiviral. NOMO FOMO, in case you missed it, recent changes in guidelines, publications, and updates. An MPOX Where Are We Now session coming up also later this month. The annual update in HIV management in New York coming up in March. Another HIV management course in Atlanta in April. And that Chicago course will be in May. And finally, another thank you for participating throughout all of the courses that we've offered. We hope to continue to provide relevant updates for you all. So thanks for joining. And thanks to you, Dr. Springer, and our IAS-USA team. Yeah, it was fun.
No, it's been fun. Thanks to the whole team, and thank you to those who participated, and thank you, Ellen. Always a pleasure. Bye.